Welcome, everybody. We're just going to wait until 10 a.m. to get started. We're happy to have you here.
You can find the handouts while you're waiting in the little go to webinar tab. There's a pull down for handouts and you can download them.
For those just joining, welcome. We're going to wait for more people to join and start promptly at 10 a.m. Welcome, everyone. We're just going to wait for everyone to get logged in. And we're going to start as close to 10 as we can. All right, it's 10 on the dot. We have a lot to get through, so we are going to jump right in. My name is Rebecca Wallach. I'm the Associate Director of the Evelyn Frank Legal Resources Program at NYLAG. Joined today, we have a great panel with myself and Valerie Bogart, the Director of the program. Peter Trubitsky, another attorney with us, is going to be looking at the questions and answers and reading those out to us. And so he's here, his video is off, but he'll be attending as well. Before we really jump in, I want to thank David Silva, Program Director of ICANN, former member of the EFLERT team, who kindly shared his slides on a presentation he's done on the New York Independent Assessor, and we've incorporated a lot of them here. So let's get started. Let's just hope that, that the slides will move, and they do. So I want to start with housekeeping. We're expecting, somewhere around 200 attendees today. And so all participants are on mute. But we do really invite you to ask questions, and we will be stopping at certain points in the presentation to answer those as best we can. In order to ask us questions, you need to use the questions and answers function in GoToWebinar. So there's a drop-down menu where you will find you'll find a header called questions and answers. If you're having problems with the webinar, you can type those questions, technical concerns into that same function, or you can email us at cle@nylag.org. A frequent question that we get is, are the slides going to be made available? Is there a handout that will be available? The answer is yes. It's already been provided to you. It's under the handouts header in the GoToWebinar menu bar. So please take a minute to look for that. The handouts are there and we've made them available. So we are very pleased to be able to provide CLE credit today to attorneys who are attending this presentation. The presentation will be eligible for 2 professional practice credits. In order to receive those credits, we will be sending out a form, a Microsoft form that needs to be completed with the 2 CLE codes and sent back to NYLAG. The codes will be announced during the presentation, so those codes need to be included, and the survey. There's really no exception to us being able to give the credit. If you email us separately with the codes, we just don't have the capacity to make that kind of exception. So you really need to fill out the form, which Peter is going to send out in the chat if he hasn't already, and we will send it out at other points in the presentation as well. So with that, let's talk a little bit about New York Legal Assistance Group. We are a leading nonprofit providing free civil legal services, financial counseling, engaging in policy advocacy efforts to help people experiencing poverty. Our unit, the Evelyn Frank Legal Resources Program at NYLAG, we are a healthcare access unit, and we're focused on fighting for seniors and people with disabilities. And we have an expertise in accessing Medicaid home care so that people can age and live independently in their homes and communities. And how do we join this fight? We're counseling clients and family members directly. We're providing trainings like this one. We represent clients in fair hearings and in external appeals, and we spend a lot of time helping clients also navigate how to access Medicaid home care through. Right now, most of our clients are receiving these services through managed long-term care plans, but as we'll discuss in this training, there are other ways to access these services as well. We also have our website, nyhealthaccess.org, where we're providing updates on the Medicaid program, which, Medicaid has many changes. It's going through many changes right now. So this is a great website to come back to read up on the policy updates. There's also access to consumer materials and treatises on a lot of these different issues, even some that we're discussing today. So we encourage everybody to visit the website. We are a nonprofit. It takes a lot of effort and energy to do the work that we were just talking about, but also to pull together trainings like this. So we are asking that if you are requesting CLE credit, or even if you aren't, that you help us keep these trainings free to the public by donating $100. Those donations can be sent in by check, or we also have the link right here, nylag.org/donate now, and you can earmark the donation to our unit. Essler, I think it shows up as Evelyn Frank program in the drop-down menu. So please consider that, making that donation. And I also really want to do a shout out to our pro bono and volunteer unit, and specifically to Valentina Chohansky, who kindly agrees to help issue the CLE credit, and it's no small task. Okay, so with that housekeeping in mind, let's jump into today's agenda. Here's what we are going to do our best to cover in 2 hours. Sort of an introduction to NIA, provide some background and some of the building blocks on eligibility for community-based long-term care. And then we're going to go through the steps of the new NIA procedure. We'll talk about how NIA and immediate need, and NIA and mainstream expedited requests, that new procedure, and spend a little bit of time on fair hearings, complaints, and resources. So it's a packed agenda, and we're going to do our best to get through it all. So let's start out with the basics. You know, what is the New York Independent Assessor, or NIA, as we're calling it for short? So just as of May 2022, NIA is the new way, the new procedure for assessing Medicaid recipients over the age of 18 to determine if they are eligible to receive community-based long-term care, or CBLTC, which you'll see in these slides. It sounds so simple, but it's actually quite complicated. And I think when Valerie and I were working on this presentation, you know, we come up against that complication, those complexities quite a bit. Not only because the way the Medicaid home care program works is complicated, but the NIA system, the way it overlays on top of that, sometimes it's hard to make sense out of it. But we've done our best, and we've done our best to go through it with also trying to provide advocacy strategies for all of us who are out in the field doing the work. So what changed and what didn't change with NIA? So now that we have NIA, we've replaced the conflict-free, or the CFIC or the CFIC assessment for MLTC enrollment. NIA replaces that, and CFIC no longer exists. NIA has included new populations. The assessment process doesn't just apply to MLTC enrollment, it also applies to those seeking home care who are in mainstream managed care plans, or who receive services at the local Department of Social Services, the LDSS, or which in New York City is HRA. Who does the nurse assessments for those populations? Who does the physician's orders for home care? That has changed. The actual order of the physician's order and the nursing assessment has changed. So we're going to go through all of that in great detail. And there's also another assessment that's been added for any consumer whose plan of care is going to be for more than 12 hours a day. It's called the Independent Review Panel. We're going to dive into all of these steps. What didn't change is the eligibility criteria for home care in the first place, or the eligibility criteria for MLTC enrollment. The assessment tool that the nurses use, the UAS assessment tool, that has also stayed the same. And this one is a good one to put out at the very beginning of the presentation. The entity that determines the plan of care and authorizes the number of hours has not changed either. it is still the MLTC plan after enrollment, the mainstream plan, or the LDSS that determines the number of hours. NYLAG does not determine the number of hours. It determines eligibility for home care and or eligibility for MLTC enrollment. And we're going to come back to this again and really reiterate all of these things, but what isn't changing yet and may change in the future. It's set to change specifically for reassessments. So the state Department of Health contemplates that sometime down the line, they haven't provided a date for this, that all reassessments or change in condition UASs will be conducted by NYLAG. And potentially at some point, eligibility for home care for children under 18 may be conducted by NYLAG, but not at this point. We want to make sure that everyone is aware of where to access the guidance that the state has put out. And so this slide is a reference for you to come back to. I'll also say that in the appendix, which is available in the handouts, we have provided the links to all of the ADMs and JISs that the MLTC policies, the mainstream guidance that the Department of Health has put out. And we encourage everyone to read through them. At the bottom, the last 3 bullets, the websites and the NYLAG updates. These are for the NIA website and the New York Medicaid Choice website. These are more consumer friendly. It's more consumer friendly information. So we recommend looking at those. You can see that I have more to say about it, but I won't here. And then our NY Health Access website is the last one for NYLAG updates on how NIA is changing. So please come back to this, and please also check your appendix if you're trying to have a reference for how the process is supposed to work. Okay, with that overview on NIA, I want to start with some of the building blocks, because as I pointed out on what hasn't changed, I want to make sure we're all on the same page on what hasn't changed, which is the eligibility criteria for home care and the eligibility criteria for enrollment in MLTC. And we're going to come back to these standards throughout the presentation. So what is community-based long-term care? In New York State, we're very lucky to have a robust Medicaid program that supports community-based long-term care and supports consumers getting services in the community to stay out of nursing homes and to live independently. This slide includes some of the long-term care services that exist in New York State, not all. Hopefully they're looking familiar to you. We have personal care, CDPAP, CHA, private duty nursing, adult day health care, and some of the waiver services that are available through the 1915C waiver services. NYLAG has done presentations, really 2-hour-long presentations, going through each of these services and reviewing the eligibility criteria for each of them. We don't have time to do that today, but I want to focus on the first two, the personal care and the CDPAP, because NIA is evaluating eligibility for a consumer to access those first two. So here on this slide, we've tried to give you sort of a cheat sheet on the overview and the eligibility criteria for these. And we've also pointed you to the sites in the state regulations. So both personal care services and consumer-directed personal assistance program or CDPAP services, this is when an aide or CDPAP worker comes to your home and helps you with your activities of daily living. And these are daily needs essential to maintain health and safety in the home. ADLs are, and we have them listed on the ADLs under our state regs, dressing, bathing, toileting, walking, eating, transferring, so getting in and out of a chair or in and out of bed or turning and positioning in a bed. There's also assistance with IAPL, so shopping, meal prep, laundry, cleaning. In New York State, where it's medically necessary, we have 24-hour split shift care for assistance with ADLs, and that's where you have 2 aides coming for 12-hour shifts. So that's the maximum amount of personal care that an individual can receive. The personal care aide for CDPAP cannot help with skilled care. So that is things like insulin injections or suctioning. Their scope of tasks is limited to assisting with the activities. So in contrast, CDPAP aides may assist with skilled needs. The program is different because the consumer or the person directing the care recruits and trains personal assistants to provide the hours that are authorized for the person who needs the care. And so we have a little bit of background there on who may or may not be the PA. But for both CDPAP and personal care, moving now from the overview to the eligibility criteria, 2 things have to be true in order to be eligible for the services in the first place. The consumer must be self-directing, so that means that they're able to make their needs, their ADL and IADL needs known, or if they can't, they're unable to do that, is there someone who can do it on their behalf? And the second one, which we're seeing a lot in the NYLAG context, is that the consumer must have a stable medical condition. So what that means, and it's stated in the reg, and we'll come back to it, is that it's not expected to, that condition, their medical condition is not expected to need frequent nursing judgment. So keep those 2 definitions of eligibility criteria for CDPAP and PCS in your mind as we go through the presentation. But then how does a Medicaid consumer access and actually get the PCS or CDPAP? And so there's actually 3 ways to receive it, through an MLTC plan, a mainstream plan, or at the local Department of Social Services. So let's kind of go through those here. So if the consumer has Medicaid but does not have Medicare, then the majority of these Medicaid-only consumers must enroll in a mainstream managed care plan. The mainstream managed care plan covers all of the Medicaid benefits, more or less at this point, including community-based long-term care services such as CDPAP and PCS. If the consumer is a dual eligible, they have Medicare and Medicaid, then if they're over the age of 21, they must enroll in an MLTC plan to access community-based long-term care. Under each of these, number 1 and number 2, we've listed out populations that are exempt or excluded from enrolling in what we call managed care, whether it's mainstream or MLTC. If you're excluded or exempt from either of these managed care products, then if you need to access CDPAP or personal care, you're going to do that at the local Department of Social Services. So many people, it's a smaller population, but smaller a number of people overall, but certain populations and many people overall in New York State still access their home care services, CDPAP, PCS, at the local DSS, at HRA. In New York City, it's the Home Care Services Program, HCSP, and the CASA program. So who are these individuals? They're people enrolled in the 1915C waivers, OPWDD, TBI, or the NHTD waivers. They may not have Medicare, so Medicaid only, but they have third-party health insurance, or they have a spend down. If you are a dual, and at the time that you need home care, you're on hospice, through Medicare, then the only way you can access PCS and CDPAP is through the local Department of Social Services. These are some of the exempt and excluded populations, not all of them. You can review them in the statutes that we cited in on the last slide. But these are populations, the most common populations that are exempt or excluded from managed care. We call them fee for service because PASA or the LDSS is giving the case to a vendor, and the vendor is billing Medicaid directly.
Rebecca, before you leave this slide, one of the questions just makes me realize let's just add a D to that, everyone. So for someone who does not need help with ADLs, if you're a dual eligible and you need help with housekeeping, but not ADLs, then you're not eligible for MLTC. You're going to be excluded. So let's add that as a 3D here. And you're going to get those housekeeping services from your local district.
Yes, let's add that as a D. And housekeeping is a Medicaid service that's available. It's a maximum of 8 hours a week, and it's for recipients or consumers who do not need assistance with ADLs, only the IADLs. That's a good question, and thanks for jumping in, Val. And another way, so we want to also make sure that people have an idea of the two types of MLTC plans. So eligibility, so there's two types of plans. There's a fully capitated plan. These are referred to as MAP plans, Medicaid Advantage Plus, or PACE plans. If you're in a fully capitated plan, all of your medical services, hospitals, outpatient clinics, and all of your home care and community-based long-term care is authorized by the plan. The more popular way to access Medicaid home care is through a partially capitated MLTC plan. And in this case, the member keeps their Medicare coverage. So they're using their original Medicare to see their doctor, or their Medicare Advantage to see their doctor for hospitalizations. But the MLTC package, the partially capitated package, includes the following. The big ones here being home care. But also, I mean, I can read through this list, but also these other Medicaid benefits, most of them are not covered by Medicare or only partially covered by Medicare. So most duals who are eligible for home care, who need those services and who must enroll in an MLTC plan, most of them statewide are enrolled in the partially capitated MLTC plans. So that is sort of some of the building blocks to have in place to make sure we're all on the same page to better understand NIA. I wanted to pause here. I see, Val, you were reviewing some of the questions. Are there any others that are sort of related to this background before we move on into the what and how and the who and the when of NIA?
Well, I'll just say one that we weren't really going to discuss, but if you go back to that slide of the requirements for personal care and CDPAP, I think so what you don't see here in eligibility criteria is that you need 3 ADLs to qualify, or 2 ADLs if you have dementia. Why aren't they listed? Because those new requirements are not in effect yet. A lot of people have heard that the law was enacted and changed in New York back in 2020 to impose a 3 ADL minimum for personal care, for CDPAP and MLTC enrollment, with the exception being for people with dementia who could qualify with 2 ADLs. That is not in effect because of COVID protections, and is not likely to go into effect until 2024 or even 2025. And so when you are evaluating right now for these services, it should just be a 1 ADL requirement for like MLTC. You need to have ADLs for MLTC or you're excluded, but you only need one.
That's it. Yes, there's again, that's kind of what one of the things I was alluding to when I was saying there's so much going on in the Medicaid program right now. I see one question about whether someone's enrolled in the Medicaid buy-in for working people with disabilities. That's if they're excluded from MLTC, and the answer to that is no. If they're eligible for MLTC, the MBI program is a financial eligibility program, and the MLTC, and for MLTC enrollment, we're not looking at financial eligibility. We're looking at other characteristics and criteria of the consumer for enrollment. So we're not even touching on financial eligibility for Medicaid in this program in today's webinar. All right, so with that, Val, I'm going to turn it over to you.
Okay. All right, see lots of good questions coming in. Hopefully we'll cover some of them and we'll have time to answer some of them. And some of them we don't have answers for because the system really doesn't make a lot of sense. But let's start with going into NYLAG. So NYLAG, this was a change in the law enacted in 2020, the same law that brought us that 3 ADL minimum, which is not yet implemented, brought us this independent assessor. But this one did get implemented because they said it wasn't a restriction on eligibility, so that the COVID protections didn't prevent the state from going ahead with it. Fortunately, it was delayed some because it took them a while to gear up Maximus. Maximus is a large private company that contracts with New York State on many, many things. Maximus runs the whole New York State of Health Exchange, Collins Center. They run the old Conflict-Free Assessment Center, and now they run NYLAG. So starting May 16th of last year, NYLAG was first rolled out solely for, sorry about that typo there, for people who are newly applying for home care, personal care or CDPAP or MLTC. And we're not receiving any of these services earlier. This is something we're going to keep stressing because it is only for someone who is not getting any of those services through any of the 3 types of modalities that Rebecca reviewed, and managed care from your local Medicaid agency. You're not getting them. You're new to home care. So when it first started last May, NYLAG was used for people who were new seeking MLTC enrollment, basically replacing the Conflict-Free Enrollment Center. So that's the one thing that's sort of the same as it was, roughly, okay. But what was new last May is that people in the mainstream plan who were asking their plan for the first time for personal care or CDPAP now needed to be assessed by NYLAG. And just as a reminder, the mainstream plans that Rebecca covered are for those who don't have Medicare. So many of us in the elder law world, we don't really deal much with mainstream plans. But there are even elderly people in those plans if they don't have Medicare. So we all need to know about those plans and how to navigate them, even if even if you mostly help older people. What also started last May is people who are exempt or excluded from managed care or managed long-term care, and they are asking for personal care or CDPAP from their local Medicaid office, the LDSS. And Rebecca reviewed those exclusions. So that would include people seeking housekeeping or people seeking personal care who are in home hospice. And the other exemptions on that earlier slide. So that was the start. Then December 1st, they rolled it out farther to people in the mainstream plans making an expedited request for personal care or CDPAP. And the definition of expedited is in the footnote on the bottom. These definitions and the timeframes come from federal regulations that say that managed care plans, both mainstream and MLTC, that gives them deadlines for how soon they have to respond to a request for a service. It also started December 1st for people applying for immediate need services from their local Medicaid office. Okay, next slide. So who's left out? Who does not need to go through NYLAG? So anyone already receiving personal care or CDPAP from their local district, from a mainstream plan, or from a managed long-term care plan. So they right now just will never deal with NYLAG for the foreseeable future. At some point, the state intends to have NYLAG take over what plan nurses do of doing the annual reassessments. And if a consumer asks for an increase from an MLTC plan or from a mainstream plan, right now it's the plan nurses that evaluate for those increases. The state plans to have NYLAG take over those, but that does not yet have a date scheduled. So now those requests are still handled internally by the plan or the DSS. Who else doesn't need NYLAG? Let's say you're getting immediate need and you had to go through NYLAG for the immediate need. After 120 days, the consumer gets a letter from New York Medicaid Choice, which is another Maximus contractor, that says, hello, consumer, you're a dual eligible, so you need to join an MLTC plan. And if you don't pick one, we're going to assign you to one. So when they pick one, those plans cannot tell them you have to go through NYLAG. They might tell them that, but you'll know that you can push back and say, no, it's not required because the person was already getting home care. But be warned, don't jump the gun. If you're on immediate need, your client has immediate need, they should wait till they get that notice from New York Medicaid Choice after 120 days. Otherwise, they're not considered receiving community-based long-term care services. If they've been getting the immediate need for less than 120 days, it's considered just short-term. And now they have to go through NYLAG. And the other thing they lose is very important transition rights. If you have immediate need and you wait the 120 days and then enroll in MLTC, that plan has to continue your same hours for 90 days. And that's all at that link there. It's a whole article about transition rights. But if you jump the gun and you go to MLTC too fast, no transition rights. So it's very important for advocates to know that, and count, if you got immediate need for your clients, counsel them on waiting, because they're going to get pressure. They get pressure from a home care agency who wants to keep the business and have them join an MLTC plan that the home care agency contracts with. That's fine. They can pick that plan. They should just wait the 120 days. The other group that do not need to go through NYLAG are people transferring from one plan to another. Or let's say they had mainstream managed care and received home care and now got Medicare, and now they're switching to an MLTC. So they do not need to go through NYLAG either, because they received these long-term personal care or CDPAP services. Some other groups that do not need to go through NYLAG are people under 18. They either request their services from their plan if they're in a mainstream plan, or from the local DSS, and people enrolling in PACE. That's the one type of MLTC plan. It's a fully capitated plan that that NYLAG is not being used for enrollment. Okay, next slide. So just to reinforce this, the MLTC plans are still doing the routine annual reassessments, and they're doing non-routine assessments. Let's say someone's coming home from a nursing home who's a member of the plan, and they've asked for an increase, or they've had a significant change in condition. So the plan is still doing those. NYLAG is not involved. As we said, if you're changing between plans, NYLAG is not required. Even if the new plan codes this as an initial assessment in terms of the NYLAG rollout, it's not considered a person new to home care. But if the person was last evaluated by NYLAG, that the new plan is still supposed to use the NYLAG assessment, but there shouldn't require a new NYLAG assessment if you're transferring plans. And the auto assignments, this has a link to various reasons why people are auto assigned. If a plan closes, or if they were in mainstream and now they got Medicare, all those automatic assignments do not go through NYLAG.
Now we wanted
So
to,
we have a
run
we have
the
a poll. Yeah. All right, hold on.
Okay, a little interactive. Sam has received immediate need for 1 month. The agency that employs the aide said Sam must enroll in MLTC Plan A. Which of these are true?
Right. We'll give everyone a few more seconds, I guess, to vote, and then we'll publish the poll for everyone to see.
Yeah, we're not quite at 50% response rate yet. Okay, I'm gonna close it. And
Okay.
yeah.
Oh, do you want to go ahead, Peter?
So most people said if Sam waits 120 days until they receive notice from New York.
Oh, so it's New York Medicaid choice, right?
Yeah.
Okay, well, so I realize this question, which I worded, is a little poorly worded, and that's true. If Sam received, the agency was MS rule, and if they, so the question got cut off. If they want to keep their aid, that was the rest of the question. All right, you know what? The question got cut off. Does Sam have to go through NYLAG? So Sam does not have to go through NYLAG if he waits 120 days until they receive the notice. So that's true. He does not have to go through NYLAG. If he does try to enroll in the MLTC plan now and at 1 month, he must be assessed by NYLAG. So those 15% of people were right. Now that would be ill-advised, right? We would never tell someone to enroll in 1 month. That was the point of this question, is we counsel the client, no, wait. You can still keep your aid, but wait 120 days and then join the plan A, okay? So the correct answer is really both A and B. But I'm sorry, the question got cut off, so it really wasn't fair. So nobody's going to win the new car because the question got cut off. But I hope everyone got the point of that. Okay, let's go to the next slide. So this is really just a review. This could be a handy chart if you keep charts on your wall of which of these groups have to go through NYLAG. But for the reassessments, and they're also called concurrent reviews under New York insurance law, none of those go through NYLAG now. That's that last column. The only plan enrollment, the MLTC plan enrollment went through, and requests within mainstream and everybody seeking home care from DSS for adults over 18 all go through NYLAG. That's the second column. So just about all personal care and consumer directed goes through NYLAG if you're not already receiving it. Okay, next slide. All right, so here's our first CLE code, and in the chat is the link to the office form where you're going to put this in. The code is dual eligible. That's 2 words. Dual, D-U-A-L, eligible, E-L-I-G-I-B-L-E.
Okay, dual eligible. I'll say it with another voice so people know to write this down and then to add the code into the form. And I think we'll move on now. Hopefully that's enough time for everybody. So next slide.
Okay, so let's break down what does NYLAG do. Instead of only one assessment that the conflict-free used to do, conflict-free assessor did 1 assessment. Now there are 2 and sometimes 3. So the first one is the nurse assessment, which was the same as conflict-free, and it's using the same assessment tool that the UAS Uniform Assessment System New York assessment, and it's done by a nurse, except now the nurse is employed by Maximus, by NYLAG. So that hasn't changed for MLTC, but that's a big change for people applying to their local district for housekeeping or home care, or applying to their mainstream plan for personal care or CDPAP, because now that nurse assessment is done by Maximus, not by the DSS, not by the plan, okay? That's step one. Step two is the independent practitioner panel. And now again, it's a medical practitioner employed by Maximus, who could be a doctor, a nurse practitioner, or a physician assistant. And they're doing what's called a clinical appointment. They abbreviated CA, and it's an exam where they're reviewing the CHA, what they call the UAS, and they review the person's condition, and if they find the person meets the minimum eligibility requirements, like has a stable medical condition, they prepare a practitioner's order. Now this order now replaces the M11Q in New York City or the DOH 4359 outside of New York City. So this is now the form that satisfies federal requirements that personal care is ordered by a physician. Now, it's that order that decides that the person meets the minimum eligibility requirements to enroll in MLTC or get PCS or CDPAP. And we'll go over then the notice that NIA sends that you're eligible to enroll in MLTC after that. And then let's say you go to your MLTC plan or you go back to your DSS and they use those forms to develop a plan of care. If that plan of care is for more than 12 hours a day, a third NIA assessment is required, and that's called the Independent Review Panel, or IRP. We sometimes call this the High Needs Review. And this is if the plan or DSS is saying, okay, we need to authorize you for 24-hour care, whether live-in or split shift. In some places, sometimes even it could authorize 13 hours of care or 16 hours of care. Anything over 12 hours a day on average has to go through this IRP. And we'll talk about these all in a little more detail. But these are the basic 2 and sometimes 3 NIA assessments. So before NIA, let's just look at how it worked. If you have a mainstream plan, the client went to their doctor, their PCP, primary care practitioner in the plan, and said, I need home care. And the doctor prepared the physician's order, an M11Q or the statewide form, and they submitted it to the plan. The plan conducted a nursing assessment. The plan determined the hours and authorized services. And if you recall before, we showed you those timelines, that request could be done expedited or standard. And depending on the timeline, that plan authorization had to come in within 72 hours after the request or 14 days. And we'll look in a minute at what's new. So the old process for MLTC or Medicaid Advantage Plus was that you first started with the conflict-free assessment, and that gave you thumbs up. You could enroll in an MLTC plan. The plan would conduct its own nursing assessment. They didn't have to use the conflict-free assessment. They could do their own. They determined hours based on that. The applicant enrolled in the plan, and the plan authorized the services. That was it. If the person was excluded from managed care for the reasons we've talked about, they'd apply at their local district. In New York City, that's HRA. They'd submit the physician's order, the M11Q, to their local DSS. The DSS would conduct a nursing assessment, determined hours, and then they authorize services. So this is the good old days. Now we go into the new world, okay? So now the person has to somehow get to NYLAG. And this is still, if they call their mainstream plan and say, I'd like to get personal care, the plan's just going to give them the NYLAG phone number and say, call them and go through the assessments. Then NYLAG is going to say, okay, we find that you meet the minimum requirements for personal care. You go back to your plan. They somehow find themselves back to the plan. This is all very awkward and poorly done. The plan then uses those assessments to determine how many hours they get, or they can still deny the care, even if NYLAG has said you meet the minimum requirements, and then the plan authorizes services. So with MLTC, the person starts out at NYLAG, and that's not as much of a change because before they started out at conflict-free. So everybody was sort of used to that in terms of advocates and attorneys and social workers. We knew about calling Maximus for that assessment. But then the individual still, as before, contacts different MLTC plans once they get this outcome notice from NYLAG, and the plan uses those assessments to develop the care plan. They don't do their own nurse assessment. They determine hours. They make an offer to the client, take it or leave it. We're giving you 2 hours a day. The client says, okay, I've been paying for a living, but I guess I'll take your 2 hours a day and fight for more. They enroll in the plan, and then the plan authorizes the services. So if they're exempt, they again, if they might go to their DSS and say, I need home care, the DSS is just going to say, call NYLAG. So you notice what's missing from here is submitting an M11Q or a physician order. That is gone. There's no more submitting an M11Q or physician's order. When we go to immediate need, there is still a form that you need to submit from your doctor, but that's the exception. If you're only looking for housekeeping, or if you're exempt from MLTC or managed care and applying at your local district, you no longer submit the physician's order. So the district will refer you to NYLAG. You'll get notices that somehow get back to the district, and the local district develops a care plan, determines hours, and authorizes services. So let's dig into this with some real practical information. All right, so how do you even get to NYLAG in the first place? You call them. And this was a huge problem when early on in last summer, you couldn't get through to their call center. We think some of those problems have gotten better, but it now has hours in the evening and on Saturdays. In that call, the person is scheduling not one, but the 2 appointments at the same time. And one of the big changes is NYLAG will look up whether Medicaid's been approved. And if it has not been approved, they will not schedule the appointment. Now that's a change because the conflict-free center would schedule the appointment even if Medicaid was still pending. And now they say it must be active. We think actually that the regulation does not require that. They're going beyond their own regulation and insisting that Medicaid has to be approved. And of course, this causes delays because Medicaid applications take a long time. Now, note in the bottom, if you're applying for immediate need, do not call NYLAG. This is not the procedure for immediate need. This is for everybody else. If you're seeking MLTC, if you're in a mainstream plan looking for services, if you're exempt or excluded from a plan looking for services, you can start with NYLAG. But if you're seeking immediate need, do not call them. There's a section here on immediate need later. So what if you're calling on behalf of a consumer? We have seen some problems with this, but a caregiver or authorized rep should be able to call on the consumer's behalf. They've provided a fax number to submit powers of attorney. They've developed their own authorization representation, authorized representative designation form. All of this information is on the NYLAG website. You can have the link there, and a copy of the form is in your appendix. So it really will cause delays though, because when you fax that form, it can take 2 or 3 days to process it before they allow the person to speak for the consumer. So it's really best to have the consumer on the phone with the rep, the social worker, to schedule the assessment, or you might be facing delays if you're faxing in this information. So this is like, you know, one of the barriers. So NYLAG will then, while you're on the phone, schedule these 2 appointments. Now, under their own directives, these are supposed to be scheduled within 14 days of the call. The only way they're able to schedule these that quickly is because they're relying on telehealth, you know, through like Zoom. And you have a right to ask for an in-person appointment for both of these, but you will be looking at longer delays. They say it's getting better, so we hope that's true. We do think that in-person assessments are much better. In fact, we think that the UAS tool was never even validated through evidence-based testing to be reliable through telehealth. I mean, it was designed for in-person assessments that are 3 hours long. So there's a lot of reason to say I really want this in person, and there's probably a lot of advantage to that. So know that you have a right to request that, and know that there will be delays in it. You can always complain about delays. Towards the end of this, we have the complaint emails. We really encourage you to complain to the State Department of Health about any delays in scheduling, about difficulty getting through on these phone lines, about phone lines not having language capacity in languages other than English, about nurses and practitioners not having language capacity. All of those things you've got to make complaints about, or else they insist that no problems exist. We'll talk a little bit more about preparing someone for these assessments. So the first assessment is the community health assessment, what we used to call the UAS. They're now calling a CHA. But it is familiar to us because it's the same tool that's always been used since MLTC started. The UAS assessment, and it was designed to take 2 or 3 hours. And they're supposed to talk to informal supports to get a full picture of the client's needs. These assessments now, remember back in the old days, these assessments expired after 75 days. And if the person wasn't able to enroll in an MLTC plan within 75 days, they had to get a new one. That has been dropped, and now these assessments are good for 12 months. So at least the person shouldn't face delays for that reason in enrolling in MLTC. Next slide. So let's give you some tips about helping someone prepare for this assessment. Whether they're doing it in person or by telehealth, they really should not be doing it alone. Someone who knows their needs should be present and pointing out what kind of help is needed with each ADL and IADL. Keep in mind that you need an ADL for MLTC enrollment. It's not enough to have all IADLs, shopping, cooking, cleaning. You need assistance with at least one ADL, bathing, dressing, ambulating, okay? It's not 3 ADLs yet, but it is 1 for MLTC and personal care, because it's only housekeeping that it's enough to show IADL needs. Now, when you look at the reference manual, which we've given you, this is what the nurses are trained on. They are told to only record the person, how the person performed each ADL in the last 3 days before the assessment, and how much support did they receive during the last 3 days. So let's say bathing. Let's say the person had no help bathing in the last 3 days. Now, if they didn't bathe, okay, it's one thing. But let's say they bathe themselves, even though they are a total risk getting in and out of that bathtub alone, even though they could, fall so easily and slip. The assessor is instructed, do not record what you think the consumer should receive or what they could do for themselves. Only look at what actually happened. So if they muddle through on toileting, everything, eating, dressing for the last 3 days alone, they are going to be denied because they will be found independent. Now, in a recent fair hearing, a judge threw out a denial based on that reasoning, and saying this is ridiculous. How can the person be independent regardless of how difficult, insufficient, time-consuming, or dangerous the task was? Maybe you can get a fair hearing decision like that, but you don't really want to go to a fair hearing. You want to get the client in the door. So, you really have to think about this. And I think part of the preparation for these is going to be figuring out what kind of help the client needs and make sure they get that help in the 3 days before the assessment, so that the assessor will say, who helped the client with toileting? Well, the daughter was here. And even if they're not there for the whole 3 days, if they were there for 1 of the 3 days, that will help. Doesn't have to be for the whole 3 days, but it has to be help within the 3 days. Also, point out cueing and verbal assistance. It's not only hands-on assistance that counts as help with an ADL. It's reminding someone to use their walker, reminding them and cueing them to eat, reminding them on how to wipe themselves after going to the toilet. It's contact guarding, which is like hands-off hovering. So all of those things count, but you have to, part of your prep is to think through every ADL and think through what help does that person need, including this sorts of verbal cueing assistance. The other thing is to be very clear about what family can do and other informal care can do and what set clear limits on what they can do. If family was there for the 3 days, but they took off from work or they need to go back to work, make that clear. Say, yes, they have been helping, but they cannot and will not continue. They'll help at night, but they can't help during the day. They'll help on weekends, but they can't help on weekdays. Be very, very clear, or it will be assumed that they can still are available. And take a look at that reference manual. And you'll see all the definitions there and you'll be better prepared. All right, Rebecca, back at ya.
Sorry, I was on mute. Thank you, Val. And I wanted to add one more thing here to keep in mind is it's sort of implicit in what we've been sharing, but to be eligible for personal care and CDPAP, the consumer needs to require some level of assistance with activities of daily living, and those are reviewed by the nurse in the UAS. But if the discussion turns to companionship or safety monitoring, someone just needs to be with mom in the afternoon when she gets back from the senior center. Those are not sufficient reasons, medical reasons to be eligible for personal care or CDPAP, and could also lead to a denial. So eligibility comes down back to the assistance with the ADLs, the stability of the medical condition, directing care, things that we've tried to kind of point out in the presentation and weave into this procedure. So into our explanation of the procedure. So I'm jumping in here on step 4. Let's see. So the UAS has been conducted by the Maximus nurse, now called the CHA. Following the CHA, we have this new step that didn't exist before, which is the clinical appointment by the independent practitioner. So this is a physician, a DO, a nurse practitioner, or a physician's assistant who's hired by Maximus to determine if the consumer is eligible for PCS, CDPAP, and or enrollment in MLTC. By design, this doctor or specialist, medical specialist, does not and cannot have an existing relationship with the consumer. That's why this step, we sort of have been saying, it replaces the M11Q. So what happened, you know, this is still quite new. We're still learning how these clinical appointments are conducted, and we've heard different things. Sometimes I've heard from some feedback that they are 5 minutes. I've heard that they could be much longer. They are conducted either by telehealth or in person. That specialist, that medical specialist, is reviewing the CHA or the UAS, and then they're evaluating for eligibility for CDPAP or PCS. So again, self-directing, has a stable condition so that they can safely receive these services in the community. Following that evaluation, the practitioner signs a practitioner's order determining yes or no. One issue that we've been raising from the beginning and from the beginning of the rollout of this program is how can a consumer or their family members who are helping them convey the consumer's medical history? How could they get a letter from their own physician to the independent practitioner? Currently, there's no way to do that. There's no system set up with Maximus to pass along those medical records. We've been advised that in a telehealth context, someone could hold up a list of their diagnoses or a recent letter from a physician for the reviewer to look at. If the clinical appointment is happening in person, you would be encouraged, if you think this is going to be very helpful to the consumer, to have medical records, copies of medical records there to pass along to the independent practitioner. Just like in the UAS assessment, the guidance from the state says that the independent practitioner can interview providers and others who may have insight into individual needs. So when you're working with a family and a consumer, you want to think through, do you need to have those medical documents if possible at the UAS with the nurse assessor, but also with the practitioner's order. And again, remember, it's all about the ADLs. So just because someone has a certain diagnosis, a medical diagnosis, doesn't mean that they're eligible for PCS or CDPAP. It's the way that those medical diagnoses lead to a condition where they do need to have some level of assistance with completing ADLs, whether it's cueing and prompting, like Val was going over just in the last slide, or really like hands-on significant assistance to complete a task, like walking. So on the next slide, we're really going to kind of hone in on this. This is the medical condition stable, and part of the reason that we're doing that is because we are seeing denials based on the fact that the independent practitioner is finding that the consumer does not have a stable medical condition and is therefore not eligible for personal care for CDPAP. So in the before times, before NIA, the consumer's own physician on the M11Q would indicate whether or not the medical condition was stable. It was a yes or no question. The stable medical condition, it's listed in the state regs. It's been there for decades, and it hasn't changed under NIA. And so there's kind of three prongs to it, right? The condition is not expected to exhibit sudden or deterioration or improvement. The condition does not require frequent medical or nursing judgment for determining the plan of care. The condition is such that a physically disabled individual is in need of routine supportive assistance, such as assistance with their ADLs, which is the point of personal care in CDPAP, and does not need skilled professional care in the home. Here we're referring to, again, nursing, someone who needs suctioning, someone who needs, someone who has a trach, someone who has skilled needs that would require that an individual have more medical training to keep them safely in the community. The condition, and then here's number two, the condition is such that a physically disabled or frail elderly individual does not need professional care, right, from a nurse, but does require assistance in the home to prevent a health or safety crisis from developing. And the idea here is that the PCS or the CDPAP intervention of the aid is going to prevent that health or safety crisis from developing. So remember, so what the takeaway for us, and the takeaway that we want everyone on this call and joining the webinar to have, is that the definition is disqualifying people who need skilled care by a nurse, because the scope of tasks for a PCA, for an aid, is to assist with ADLs and non-skilled care. But note that there is a little gray here, because CDPAP workers who are hired and trained may assist with skilled needs. And that's something that if you know that you're assisting a consumer that does have skilled needs, you're going to want to be able to share with the independent practitioner, we're looking for CDPAP and we're going to hire people who can do the insulin shots. And you want to make sure that that gets into the record. You know, scope of tasks for an aide, we could do another whole hour-long presentation on this issue, but one important thing to remember is medication administration. And you want to make sure that there's a plan for someone who's seeking PCS, the personal care with the home care aide, around for someone who is not self-directing, how they are going to be taking their medications. An aide can do certain things around medication, but they cannot put medication into the consumer's mouth. The consumer needs to be able to do that themselves. And an aide for PCS certainly cannot administer insulin. So when we get to the fair hearing section, we do touch on and review some of the fair hearings that are bringing these cases in front of fair hearing judges and winning reversals. But as Val said, we don't want to go to a fair hearing. We want people to get through NYLAG and be approved and be able to start accessing services. So thinking about these issues on the front end would hopefully prevent having to go to a fair hearing on the other end. Okay, so that got us through step 4. We've gotten through the first 2 assessments, and now I'm going to go through the outcome notices when the program works and when our consumers are approved to proceed either to MLTC enrollment or to access CDPAP or PCS through their mainstream or LDSS, mainstream plan or at the LDSS. And then after I we'll take some questions, and after I get through that, we're going to send it over. I'm going to send it back to Val to go through some examples of what these notices look like, specifically focusing on people who are denied. So you've gone through the 2 assessments. You had your CHA, you had your clinical assessment. 2 to 3 business days later, under their own guidance, NYLAG should be sending out an outcome notice. In our experience, we've had cases where it's taking longer, but that notice should be issued right after the IPP, and it should be put in the mail to go to the consumer. That notice is so important. Everything stems from that notice at this point. So you want to counsel the people you're working with to be watching out for the outcome notice and to not throw it away, to keep it and share it with you. So if this was a dual eligible who went to NYLAG to enroll in an MLTC or MAP plan, the notice will say whether the consumer was found eligible to enroll. Assuming that it says yes, the next step is to start contacting MLTC plans to do the mini assessments where they come to the home or do telehealth to assess night needs, informal supports, and consumer preferences. Following those mini assessments, the plan should offer, their plan of care and what the authorization of hours is that they're going to provide. Remember that enrollment hasn't changed. So enrollment in an MLTC plan must be completed by the 18th of the month for services to start the 1st of the following month. And that's the kind of delay that's baked into the system. So today, if I had an outcome notice approving me for MLTC enrollment, I would be working, it's the 8th of the month, I'd be working really hard to talk to MLTC plans to have them do the mini assessments and offer me a plan of care. And I would be working really hard to sign the enrollment paperwork for services before the 18th so that services could start on March 1st for me. Possible that I might not be able to do that in 10 days because I have other things going on in my life and the plans might be busy, in which case they would come and do their mini assessments after the 18th of February. If that happens, and I find the plan that I like, the first day that I will receive services in my home from the MLTC plan would be April 1st. This is not new. This is the system that has always been in place, you know, under the conflict-free evaluation. So keep that in mind as like another place in the enrollment process where there might be some delay. We have a note here. If by chance the plan is going to offer you more than 12 hours a day, so either live in or split shift, then they're going to have to refer you to the independent review panel, or the IRP. I'm going to touch on that a little bit, but please take away that our advice right now is to enroll before, even while the case is pending with the IRP, to prevent that delay I was just going through. Instead of services starting today on March 1, on April 1. So all rights for MLTC members stem from enrollment once they become members, and so you don't want to delay MLTC enrollment while you're waiting around the plan of care, because you can ask for more services once you're enrolled. If there's some sort of denial, there's a right to request a fair hearing against NYLAG, and we'll go through that. Okay, so what if you're a mainstream member? Remember, you're Medicaid only, or you're excluded or exempt from managed care, and so you're receiving services at the LDSS, HRA in the city. Well, this is a really huge shift that people need to wrap their minds around, and it's a system. The system has created something that's really onerous and confusing for consumers. So just like previously, the CHA and the CA have been conducted 2 to 3 business days after completion. The outcome notice should be sent in the mail to the consumer. Again, they want to keep this notice. Everything stems from this notice. The notice will say whether the consumer's medical condition is stable to receive PCS or CDPAP. And remember, it must be stable in order to be eligible for that Medicaid service. And the notice will say they may be eligible, assuming that the condition is stable, to receive CDPAP or PCS. At which point, assuming that's what the approval language looks like, at which point the consumer must take that outcome notice and contact their mainstream plan or the Department of Social Services and provide that outcome notice to the plan. In other words, NYLAG, there's no connection between NYLAG and the mainstream plan to alert the mainstream plan that a member is in need of personal care services and they underwent the assessment and this was the outcome. And there's no connection between NYLAG and HRA or the LDSS. Now, for this population, the exception is immediate need and the exception is an expedited request. But we are very concerned that consumers who are in mainstream plans who don't have expedited requests, or who are excluded or exempt from mainstream and haven't gone through the immediate need process, have gone through NYLAG. They have outcome notices that are mostly approving them for personal care, and they're not connecting back with the mainstream plan or the LDSS to access those services, and they're just sort of lost in limbo. So what we can do as advocates is to understand the system and really try to connect people who are in mainstream or LDSS back to those plans. And it's an area where hopefully there will be changes as NYLAG progresses. Assuming the consumer does get back to mainstream, get back to the plan, to the entity that will be authorizing the care, the plan will then, or the LDSS will then follow up, do mini assessments, and develop a plan of care and authorize services. If the services are denied, then the plan or the LDSS gives the denial notice with fair hearing rights, and you could go to a fair hearing against the plan. So the last step is interrelated here. Should the MLTC plan, the MMC plan, or the LDSS plan approve more than 12 hours at that initial first authorization, so this means live-in or split shift care, then the plan or the LDSS must refer the case to the NIA Independent Review Panel, the IRP. The IRP is to review the NIA assessments and any documentation from the plan to determine if it's reasonable and appropriate. The IRP may recommend changes in the plan of care, but not a specific amount of hours. The IRP panel may speak to the applicant, the representative, the primary care practitioner to better understand the consumer's needs. So what comes out of the IRP is a recommendation about whether live-in or split, whether that plan of care is appropriate for the consumer. It is but the important thing to know as advocates is that the plan, whether it's MLTC mainstream or the local DSS, only has to take the outcome from the IRP is a recommendation, and it does not need to follow. They do not have to take the IRP recommendation. It is up to the plan, to the DSS, to determine the plan of care and to review that plan of care and support, agree with it, I guess I'm trying to say. So what we've heard from, in our, sort of from HRA is that their CASA program is, not frequently, but has been using the IRP process in certain initial authorizations. And for the most part, the IRP has agreed with HRA's CASA program when there's been an authorization for live-in or split shift. I think in our experience, it's going to be more likely than not that the IRP is going to be used at the DSS level, because it's very rare for an MLTC plan to authorize live-in or split shift at initial application. Okay, so that is steps 1 through 6. In the interest of time, I don't know if there are any questions that make sense to read out, Val or Peter, but I see that we're getting close on time and I almost just want to proceed.
Yeah, I mean, there have been a few questions about housekeeping.
Yeah,
but
we have a slide.
Yeah, let's move on. Okay, so I'm gonna hand it back to you, Val.
I'm gonna do my best to answer them in the chat.
Yeah, but if people just stay with us, we're getting to housekeeping, a specific slide. So just you got to hang in there, okay? Everyone wants their questions all answered within the first 5 minutes, but it's a 2-hour presentation. So here's, you can see already there are problems here, and the problems are we think are pretty serious. And the process of how it should work, which Rebecca laid out, like, that's bad enough, but wait till you see what the outcome notices are. It's pretty tough. So let's look. Go ahead. So basically, NIA is asking 2 questions. Like, are you eligible for personal care or CDPAP? And the answer is no or maybe. It will never say yes, because they're sending it back to, well, they're not sending it back. They're telling the consumer you take it back to your plan, your mainstream plan, or your local district, or your MLTC plan that we're going to tell you yes or no you can enroll in, and they'll decide if you're eligible. We're only saying that you qualify for one basic criterion, in that your medical condition is stable. That's the one condition, okay? Now, are you eligible to enroll in MLTC or MAP? They will say no if they find you don't need 120 days of community-based long-term care. So that is basically shorthand or to translate, we don't think you have any ADL needs. I mean, that's an ADL needs that would last 120 days. So those people are going to be found, no, you're not eligible for MLTC. That's the most frequent reason we're seeing in these outcome notices for denying someone MLTC. They can also be found, your condition is not stable for personal care or CDPAP, but that's not a reason for saying you're not eligible for MLTC, because MLTC plans also provide private duty nursing, which can be for people with an unstable medical condition. So that's where the maybe comes in. You have community-based long-term care needs, and they're ducking it. They're not making the final decision. They're ducking it to the DSS or the plan or the MLTC. The next slide, please. So here's just a sample that there's a section where it says your assessment was completed on X date and it shows X. So examples are you may be eligible for community-based long-term services and supports. You may qualify to receive them through a plan. Your health condition is not stable. So you need to get this notice, and we're going to try to help you sort through what it means and a couple of examples. So here's a mainstream person who's applied to be assessed to get personal care or CDPAP. So one of the things I hate is that it says the exam helps find out if your health condition is stable. It doesn't help. It determines if your health condition is stable. It is a government contractor that is making this determination. So on this one, it finds your clinical exam shows your health condition is stable to receive personal care and CDPAP. So there you breathe a sigh of relief that client has met the main criterion for, or at least a threshold criterion for getting personal care. But then it doesn't say whether you are eligible. It says call your plan and ask for services. So, and the plan will still decide whether they think you have ADL needs. So someone in a mainstream plan is not being determined by NYLAG that they are eligible for personal care, only if they are not eligible. Then the plan will do its own sort of mini assessment. They still have to use the NYLAG assessment as the basis for developing a plan of care and determining the hours. But they can still deny services if they think, okay, your condition is stable, but you have no ADL needs. You're independent. Now, the mainstream plan should also be reviewing for housekeeping needs. Let's say someone is independent for personal care, but because of their disabilities, they need help with laundry and shopping. So they should be assessing for that, and we're seeing that plans are not. They forget that housekeeping is a standalone service it's limited to 8 hours a week, but the mainstream plan should be assessing for that. Next slide, please. So here's someone who's applied for MLTC, and this one shows your health condition is not stable to get personal care or CDPAP at home because of depression. Sorry, I have to laugh because, like, since when do we not give home care to people because of depression? And you have behavioral disturbances and agitation. So it's not finding that you're not eligible for MLTC. Rebecca, can you just show us the rest of the notice? It says you may qualify to receive other long-term care services through the MLTC plan. So because MLTC plans do adult daycare, they do private duty nursing. So just because, even if it's true that your medical condition was not stable to qualify for personal care or CDPAP, you're still out. You could still be eligible for MLTC enrollment and need the other services. But if you really think, I mean, this is the kind of thing that you would want to appeal. But is this notice appealable? I'm not even sure.
Well,
It's not denying you enrollment.
But you may never be able to be enrolled because the MLTC plan is very ambiguous. So you can request a fair hearing off of this one.
You
This
think?
is an example from one of David's cases. May request fair, yeah. This is a quagmire, and also depression and behavioral disturbances. You know, when you just read those, you don't think, oh, this is someone who needs skilled nursing care in the home to be stable. So a lot of questions with this set of facts.
So one suggestion is to ask the plan to request a variance. We have not talked about these yet, but there's a whole section of the regulations and all the directives in which a plan or a DSS can ask NYLAG for a do-over. They can say, look, we just think this assessment is wrong. And they have to, for them to do it, they have to point out very specific facts that are wrong, and ask them to redo it. The consumer can also ask for a new assessment from NYLAG. And we know that NYLAG is giving all sorts of weird answers to those requests, saying you have to wait a year, you have to wait 60 days. The NYLAG administrators tell us anybody can request a new assessment if their condition has changed. So, you know, that's one way around it. But they should be able to request a fair hearing on this one. So now this one says point blank, you are not qualified to enroll in an MLTC plan because you do not need one of the long-term care services listed below for 120 days. So even though your condition is stable, this is the one that translates, we don't think you have any ADL needs. Now this one says you can't get MLTC. So your choices are to appeal it and say this is wrong, to go take this to your local DSS and say, okay, I want housekeeping services. It does find that my condition is stable, and you're hoping that the CHA assessment will tick off some housekeeping needs, because then that would justify housekeeping. You won't know that till you see the actual assessment, and you don't really have a right to get the assessment until you request a fair hearing. So I think that the strategy here would be to take this to your DSS and say, I want housekeeping. If they deny it, appeal that, and then you can get a copy of this assessment and dispute the findings. Or do both, appeal it if you really think you have ADL needs, and to enroll in an MLTC plan. So you can see these notices are just not what we are used to in terms of having a clear finding. I mean, how helpful is it that the state paid a lot of money to this contractor only to say, you may be eligible, but maybe not? Like, what, how does that help? Now, here's another one that says you do not qualify, and you're not stable, and you need, yeah. So you're not, your condition isn't stable. So this is one where your really only avenue is going to be to request a fair hearing and prove that they're wrong. Your condition is stable. We went over the slides earlier on stable, the standard and the regulations for what is a stable medical condition. So, you know, attorneys and paralegals are used to taking a legal standard and showing the evidence to prove that the client meets that standard. And so these hearings are winnable. And if we don't get to it, we have some slides at the end showing some, and in your appendix, some favorable fair hearing decisions on these issues. All right, so here's one where it does say your condition is stable, so that's good. And you may qualify to receive services through an MLTC plan, which essentially means that they found that you need more than 120 days of community-based long-term care. So here's the problem. The plans still might deny enrollment because they want to see in the CHA very specifically that the person has strong ADL needs. And here, we'll talk about on the next slide, like what they're looking for. So we've gotten this question a lot. The plan says, well, we can only give you 12 hours a week because that's all the state allows, or that's all the NYLAG assessment shows. So translation, the NYLAG assessment does not say how many hours you get. It's the plan that decides that. The plan is free to give you 24-hour care regardless of what the NYLAG assessment says. But there are a few, reasons why the plan might be saying that. One is their payment. Now, they get paid the same rate for every member by the New York State Department of Health. That rate is negotiated. It's based on a lot of complex factors. But one of the factors are the ADL scores of their membership. And they throw that into a big computer and they aggregate it and they come up with a average score. They call it the acuity of their members. So they're always looking at what their rate's going to be next year. And if they enroll a lot of people with low ADL scores, saying you only need like help with one ADL and it's not a lot of help, it's just very little help, they know that their rates will go down ultimately they're dealing with thousands and thousands of members. So when they say they can't give it, that's why. The other reason it's not on this slide is, they could be concerned about being audited. If they're giving too much care that's not justified by the nursing assessments, I suppose they could be audited and reprimanded for giving too much care. We wish that was a real problem. We've never seen plans giving what we think is too much care. So some recommended strategies: you can ask the plan to request a variance from NYLAG, and this is the redo of the CHA based on a clinical or factual error. You can ask the plan, look, can you print out this NYLAG assessment? And let's look at it together, and I will show you which ADL scores I think are wrong, and I'll tell you why, and you can help them prepare the variance. There is a factual error here. It says that the client is independent with ambulation, and you know that that's not true. And so you could say, this is, now I don't know if a plan would ever be willing to do this, but this is what we're suggesting. Now, of course, a variance can cause delay, and the consumer even has a right to refuse the redo. But, you know, in the long run, sometimes the delay is worth it if it means getting the hours. I mean, if the family can muddle through and provide informal care in the meantime. The plans are also reluctant to request too many variances because they get dinged with a penalty if they ask for too many. Another strategy is just take what they're giving, take the 12 hours, enroll. As Rebecca said, you always have to your eye on that 18th of the month clock to get in for the next month. The consumer only has rights once they're in the plan. Once they're in the plan, they can request an increase right away. We talked about expedited increases before. You can ask for it to be expedited. The plan has only 72 hours to decide an expedited increase. You can use this time while they're waiting to get that request ready, get a good doctor's letter. If you're asking for nighttime care, have informal caregivers or your private aides keep night logs to show the frequency of need. On day 2 of enrollment, fax all those into the plan to request the increase. And that can be appealed, first in the plan appeal, then at a fair hearing. If everything's done on an expedited basis, this process can go quite fast. And don't forget, NYLAG is not involved once you're in the plan, and the plan can do a new assessment. So now let's switch over to the mainstream plan. This is a myth we hear a lot, okay? And we hear it from NYLAG. If you want personal care, you need to switch to an MLTC plan. Wrong, wrong, wrong. Mainstream plans are required to give personal care in CDPAP, including 24-hour care. And a mainstream member is only allowed to switch to MLTC if they need a service that's not covered by their plan. And there's only 3 of those services listed here: social adult day, environmental modifications, or home delivered meals. That's it. And there's a policy there. You can download it. So they should not be pushed into switching to MLTC. I mean, they might want to, but there's really no benefit to switching to MLTC. These plans can still give 24-hour care. Now, the same plans will say, well, we can only give you 6 hours a week based on this assessment. So again, it's the same thing. NYLAG does not determine hours, the plan does. So again, if the assessment finds the consumer very independent, you can ask the plan to request a variance, the redo, and if the plan doesn't give you enough hours, you can appeal it, and just appeal it up the appeal chain. Okay, next slide. All right. So here, there's been a lot of questions in the chat. Please listen. People who asked about how do I get housekeeping? Here you go. All right. So you're someone who's exempt or excluded from MLTC, and because you don't have ADL needs, right? Or you're exempt because you're in a TBI waiver, or you're in OPWDD. So you apply to local district for personal care or CDPAP. If you're not applying with immediate need, so once Medicaid is approved, you first have to apply for Medicaid. Once it's approved, you may call NYLAG directly, and the earlier slide gave you the numbers. If you ask the DSS for home care, they'll just say call NYLAG. So there's really no point in asking the DSS. Once NYLAG issues the outcome notice, it's up to the consumer to loop back to the DSS and provide the copy of the notice and say, I want housekeeping. Or if you're an OPWDD, I want full-on 24/7 personal care or CDPAP. Or same if you're in home hospice. Now, in New York City, these requests go through Home Care Service Program Central Intake. And that's where you fax your outcome notice and some kind of cover letter saying what it is you want. All right, whether it's only housekeeping. Now, if you're a dual eligible and you're not exempt, all you can get is housekeeping. We have mandatory MLTC in this state. So if you were denied MLTC, it's not like you can say, all right, I'll take personal care from HRA. No, only if you're exempt or excluded, or if you're only seeking housekeeping, then you go here. Now, HRA has had a lot of problems with its home care service programs, faxes, and phone numbers. They've explained to us that they're moving their whole unit to another building. I don't know. It's a hot mess, as is so many things. So if you can't get through, if you try all these things, that you can contact us, flirp@nylag.org, and we might be able to troubleshoot, but or give you some other suggestions. But this is how you're supposed to apply for housekeeping after you've gone through NYLAG. So then HRA develops a plan of care. They'll do a home visit to ensure it's a safe environment. And this is also true if you're exempt from MLTC or excluded. And then they issue a notice, which you can appeal at a fair hearing. All right, next slide. I'm going to try to go very fast.
I think this is,
Oh, that's it.
okay, so now I know there's been a lot of questions about immediate need, and we're in our final minutes, so I'm going to sort of pare this down and start on this slide. I'm seeing that there might be some issues with the handout, so we will make an effort to send out the slide handouts and the appendix over email after the presentation so that everyone has access to them. But for things that we end up speeding over at the end of this, please come back to the slide as a reference. So as of December 1st, any immediate need request must now use this new NYLAG procedure that we're going to review. Big picture, what is immediate need? Immediate need is a fast-tracked way to get Medicaid eligibility if necessary and personal care or CDPAP in the community from the LDSS, because there is an urgent need for the care, and you can review how urgent is defined in the previous slides. So how do you, there's multiple steps here. It's so far, first you apply, then the LDSS will review the paperwork to see that it's looking okay, and they will contact NYLAG with a three-way call. I'm going to go through this in a little bit more detail. And then there's a fast track unit at Maximus at NYLAG that should be scheduling the CHA and the clinical appointment within 6 calendar days. And then an outcome notice is issued, and then the plan of care is developed. So what do you include in your application to the LDSS? We've listed all the documents here, and we've provided copies of the forms in the appendix. These forms in New York City can be faxed to this e-fax number below, specifically and only for immediate need cases. So two forms have been updated as a result of the new NYLAG procedure. The first one is number 3, the attestation of immediate need, DOH form 5786. And then number 7, the practitioner statement of need. This replaces the M11Q. It must be completed by an MD, DO, nurse practitioner, or physician's assistant. And it doesn't have the same rule. It's very simple. It's a very simple form, and it doesn't expire the way an M11Q used to. Remember, those were only valid for 30 days before they went moot. For a period of time that we're still in right now, if a consumer submits an M11Q, that should be processed, as equivalent to this new form. So the LDSS receives the immediate need application. Remember, these individuals who are being fast-tracked, they do not contact NYLAG directly. Instead, the LDSS will review the packet and they will submit a new form. I have a picture of it on the next slide. This form is submitted by the LDSS to NYLAG via a dedicated URL. It goes into the system at Maximus, and once it's fully in the system and live, I guess, then the LDSS home care unit gets on the phone with the consumer and with the specific unit at NYLAG to schedule the assessments, which must be scheduled within 6 calendar days. And, the process starts to look very similar to what we were just reviewing for quite some time. The 2 assessments are conducted quickly, and then the outcome notice is issued. In this case, because the LDSS is connected to the consumer, there's not as much burden on the consumer to get that outcome notice and get it back to the LDSS. The client should still be looking out for that notice and providing you with a copy of it. The reason is because the LDSS is receiving daily and multiple kinds of reports from NYLAG on the outcome of their fast track assessments. And so if you are connected to a caseworker at the LDSS or at CASA, you can be following up with them to find out, what was the outcome of those 2 NYLAG assessments. And then after that, the LDSS is going to review the NYLAG assessments and do their mini assessments and authorize care. If it's for more than 12 hours, it would have to go to the IRP. And so here we are at 11:57, our second CLE code for everybody. The CLE code is immediate need. So it's immediate need. That's the second code for the CLE credit. You're going to want to put that into the office form. We've provided that link to you a lot of times in the chat. In order to get CLE credit, you're going to need to use the first code. The second code is immediate need. Fill out the survey and send that to our pro bono and volunteer unit. So the code is immediate need. Hopefully you guys are all typing that down and making note of it. So I had a request to see this last slide. The slides should be available in the handout section if you're looking for them now. I think I'm seeing concerns with people with the appendix not having all the pages. So there's also a new procedure for people who are in mainstream plans and need services, personal care services ASAP. Why? Maybe they are having a nursing home discharge. Maybe there was a stroke, a case where someone had very advanced cancer. Those are cases where an expedited authorization is needed. It's a similar process where instead of contacting NYLAG, the consumer needs to find the correct unit at their mainstream plan, and they need to our advice would be to have a documentation from one of their physicians saying that the request should be expedited, and we have the standard here from the federal reg, because a delay would seriously jeopardize the enrollee's life or health or ability to attain, maintain, or regain function. We would want that in writing to have that expedited service. And so I don't know if we want to go through these slides or just, Val, do you want to?
if people, you'll get CLE credit even if you sign up at noon, but if you want to stay for a minute, it's just a few more slides. If you get that outcome notice and you're seeking MLTC enrollment, and it says you are not eligible to enroll in MLTC, you can request a fair hearing. And the notices have the time limit, which is 60 days. You're requesting the fair hearing through the same system that if you do Medicaid or home care MLTC, it's the same as we've always used. It's run by OTDA. And we do understand some advocates have called on the phone and made the request to expedite the fair hearing. And those hearings have been held in like 3 days. So that's really fast. Now, you need to prepare for those hearings with the evidence, getting the evidence packet. So here's the email address to request it. And unfortunately, those can take a little while to get. You want to see the CHA. You want to see the physician's order. You want to see all these assessments because that's how you have to build your case. And those might getting those might get in the way of expediting the fair hearing. But you just want to ask for them right away. And so NYA, it's their decision. You've been denied MLTC enrollment. They're the adversary. They're the one defending the case. But it gets mushier when you're asking for personal care or CDPAP from a mainstream plan or from your LDSS. Look at all those notices. And mostly you can't appeal those notices. They say contact your DSS or plan and they'll decide whether you're eligible. So it's the mainstream plan or the LDSS that denies services and they issue the notice. So that's where the guidance says that the appellant or the plan may call NYA as a witness, but they don't say how to do that. And so I don't know, we haven't done that yet. I don't know if people have done that. So that's one of the challenges, but you can at least get the documentation. Next slide, please. So we just wanted to give you some hope. People have won some fair hearing decisions. There are basically two possible issues at these hearings. One is that they found your medical condition was not stable. And this was a very good decision. I urge you to read it. You can just plug in these numbers at the link on the bottom to find these decisions in the OTDA Fair Hearing Archive. And they're inspiring because you see judges, have the voice of reason and say, what do you mean? The fact that this person has a neurological impairment that makes them at risk of falling does not render their medical condition unstable. It doesn't require a nurse making frequent professional judgment. It just requires an aide. That's what home care is. So, reading the decisions can give you a sense of what, how to frame your own argument for a hearing. Warning that it can be difficult to implement a decision because if the CHA, the UAS said person has no ADL needs, and now the judge is saying, what do you mean they have no ADL needs? Yes, they do. Once you get to go to an MLTC plan, they're going to say, we can't enroll you. The only CHA on record says you have no ADL needs. You need a new CHA. So this, we heard about one of our colleagues has gone through this ordeal, and I'm not sure in the end if the client had to get the new CHA or not. But so you might want to ask the ALJ to be very specific that requiring NYA to enroll you without requiring a new CHA, but this can still be, this this stuff has not been worked out. They did not think through how fair hearings would be implemented when they launched this new system. Okay, well, thanks for staying over. We do have references. You want to just go back, Rebecca, to some of these reference slides. Just here are the very important, the complaint line, delays, bad CHAs, inability to get an in-person assessment, the inability to get Spanish or Russian or Arabic assessment. Complain, please. If they don't hear about it, they don't know about it, and they think there are no problems. And there are separate complaint units for both mainstream managed care and MLTC. So think about which to use. But the independent assessor complaints is for everybody if it's a problem with the independent assessor. All right, so there are a bunch of other references here. And again, we're asking for donations. I mean, we all know anyone who gets CLE credit, you're paying for the bar. You're paying for the PLI. We are, as a public service, we're doing this for free, but it's not free. Believe me, it is not free. So we really, and our grants do not cover all of our costs. So we really ask you to make a donation.
There's a question. Reiterating all of that, and there's someone who asked if we could repeat the CLE code, and they're still on, and it's afternoon, so I'm just gonna repeat it and go back to that slide. The second code was immediate need. Sorry, it's taking a long time.
All right, but we left it on for a while, so somebody was multitasking. And
they've made it up by staying for longer. So yes, it's not free. So if you can help us by making that donation and helping us keep them free, that would be wonderful and most appreciated. So we will make sure that people get the full appendix and slides, and we do believe that this recording will be made available in the coming days, weeks. So thank you everyone for attending. We really appreciate you, and hopefully we've clarified something about this new complicated system that we are all learning about right now. So thank you.
Thank you. Bye-bye. Did you stop?